some minutes so we can already start. We are 16 people already, but people are getting in, so no problem. They will be able to catch up. So nice to see you. Thank you, all of you, for attending this session. Today we are very pleased to have with us Jacqueline Broerse. She is Professor of Innovation and Communication in the Health and Life Sciences at the Vrije Universiteit of Amsterdam. She is also the director of the Athena Institute for the Transdisciplinary Research at the same university. Her work focuses on sustainable and inclusive system change in the health and life sciences and across and beyond. Her current research is dedicated to methodologies for multi-stakeholder engagement in research and innovation processes. Jacqueline is an expert in designing approaches that facilitate knowledge co-creation and joint reflection with stakeholders from academia, but also outside. And her research is also dedicated to the governance of system transformation. Jacqueline is committed to promoting open, inclusive, and equitable system transformation to drive sustainability transitions. She is the coordinator and also has coordinated several EU-funded projects on sustainability system transitions and has many advisory roles, such as, for example, she is a board member of Global Health Program of the Amsterdam Public Health Institute. Today, she is going to talk about how can we address persistent challenges in health systems, which are persistent because they are rooted in complex systemic barriers. The session is entitled Addressing Persistent Problems in Health Systems, and it will highlight the need for transdisciplinary systems thinking and new approaches for collaboration, reflexivity, and inclusive innovation across sectors. Dr. Broerse will also share case studies from her work across different countries, offering practical illustrations of how system change efforts unfold in different contexts. Jacqueline Broerse, welcome, and thank you very much for sharing with us your know-how and your knowledge in food system transformation and in health system transformation.
Well, thank you very much for this nice introduction, Rosina. I think I can share my screen. I think that would be the best option at the moment. Am I allowed to? Yes, that's always very nice. Yeah, share screen. What I need to check then is when I go into presentation mode, I need to check whether you can see the right screen or that I need to change screens.
This one is the correct one.
Okay, then I'm right on the spot. Perfect.
Thank you.
Rosina, how much time do I have?
You have 40 minutes for your presentation, and then we can open the room for questions and answers.
Okay, perfect.
And comments.
That should work out fine. Okay, what I will talk about is, I will give a brief introduction, of course, then I will go a little bit also into health system reform, because I want to talk quite a bit on health system innovation, so changing the health system as such. And health system reform is the way that is currently shaped. I will go into a bit about Rogers' diffusion of innovation model as more of a bottom-up idea of intervening in systems. And then I will go into the system thinking and the real system innovation. I will use examples throughout. The basics of the presentation is from the book Towards Sustainable Transitions in Healthcare Systems that I edited together with my colleague John Grin of the University of Amsterdam, the other university in Amsterdam. If you would like to do a read up, you will find most of the things here. Just systems, when we're talking about systems, just to make sure that we're all on the same page, is that it's basically all organizations, people's actions to promote, restore, or maintain health. It also includes the determinants of health. So on how to improve health, basically any activity that has as its target. That is part of the health system. So it's rather broad. And what you see is that in many cases, when we say, how does the system look like? And if you look at models for the health system, there is one predominant model, which is based on the model of the WHO. But there are also more updated versions, is that they look like this. Yeah, you have a certain input. You have the governance as an input. You have resources, staff, infrastructure. You have finance. That leads to service delivery, that leads to certain outcomes with respect to things like, are the needs of people met? Is there some justice in a system? Is a system effective and efficient? All with the idea then that those outcomes will lead to good health. So that's basically what this thinking about this. So this is a very specific way of depicting a system. It's what we call a systems model with an input, a conversion, that's the health delivery, and then an output and outcome. That's the there. When we look at problems of the health system today, we often also look not only is it effective and efficient, but we also very much look at certain quality criteria or so, what we want to achieve with the system. So what you also see is that systems are underpinned by certain values, like affordability, accessibility, acceptability, quality, equality, all name it. There's a whole range of values that we feel that the health system should fulfill. And what you see nowadays, if we're talking about that we feel that the system is not doing what it should, we often say that there are imbalances in the system. There are imbalances. We want to continuously improve to make sure that the different values are, in our opinion, and that's very subjective, sufficiently fulfilled. And what is wrong now, what's the problem with the current system, is that we don't feel anymore that that's the case. So there are issues with over-medicalization, in the sense of that we want a pill for everything. And also that we have antibiotics for everything, which leads to antimicrobial resistance. We have demographic changes, which severely put pressure on the health system, and that is mainly due to the aging of the population. We have an attitude of patients who are demanding quite a lot from the health system, and increasingly. We have all sorts of new pharmaceuticals and therapies that are more and more expensive by the day without much health gain. We see changing burdens of disease, increasing numbers of NCDs as a result of lifestyles. And all in all, what we often, what many governments are most concerned about is the increasing costs. So all these things make us feel that there is an imbalance. Yeah, so we have problems of keeping it affordable. As a result of rising costs, we have a problem of keeping it accessible. In some cases, you may wonder where the needs are really met, and also quality is under pressure, leading to staff shortages, etc., because of increasing demands on this health system. So we have a problem with the health system. It's widely acknowledged. So Wild felt need to do something about it. So there's widespread dissatisfaction with the healthcare system. And there are many pleas for radical changes. By the way, if anybody would like to already ask a question along the way, I don't mind. Just raise your hand. I can see where hands are raised. So if you have an urgent question, don't hesitate. We're not with that many people, so it can be a bit more interactive. Don't shy away from it. So what you see that most governments do is trying to achieve top-down changes. So they usually try to change something in the structure of the system, like changing the insurance, changing something in the regulations, changing something in the infrastructure, changing something in the education. These top-down changes are, for example, just to give you the more specifics, it's about increase of activities of the private sector. So more competition. So, and we see it worldwide, that we see a move away from the social fabric of the public sector emphasis in many health systems towards these liberalization laws, allowing more private clinics, but also within municipalities or other levels of government going for contracts. And going to, so as that they see, well, we need more competition that will reduce costs. That's the idea. More, so that's a structural thing. We see things like user fees or own risk that are increases in the health insurance. So that actually people pay more out of pocket. We also see in many cases decentralization, the idea that if we decentralize, the healthcare system will be better able to meet the needs of people, because if you're doing too central, you are too far away from the grassroots level. If you move your healthcare closer to that level, it will be better for responsiveness. You see things like task shifting. So doing the tasks at lower levels. Another thing is that we have an emphasis on evidence-based healthcare, like guideline developments, protocols, other things should be based on evidence of effectiveness. So hopefully that will improve this effectiveness and efficiencies and reduce costs, so that all these treatments that are actually not evidence-based can be kicked out of insurance and actually lead to better results. We see increased accountability. Are you really spending the time? So we need to administer more. Administration needs to, but we need to do user satisfaction. So we see this whole bureaucratic system being built up to such an extent that lots of healthcare providers are complaining that they don't spend any time anymore on their patients. All with the idea. Now, if you look at all these different reforms that are taking place, sometimes simultaneously, sometimes over time, one tried this and then the other, but we don't see that much improvement, and that's a problem. So we don't see much improvement in quality of care, we don't see much improvement in the reduction of costs, basically because, and that's one of the important assumptions, is that actually the way we're thinking about this and actual practices not necessarily change that much. And we see that many actors try to keep things the way they were and are not going to try to, well, they're trying to work around these new structural things, or simply they do go along, but the change is not radical enough. That's another problem. So there is a change, but other problems were overlooked. So actually, in the end, nothing much happens. And that's a problem. Another thing that is being tried is to say, okay, we need to make new innovations. Actually, research and innovation are key in improving health standards over the past decades. So the incredible improvement in life expectancy, etc., is to a large extent due to research and innovation. This is an important route. We also, in many cases, see this as a more bottom-up route, in the sense that you try out new things in small-scale settings, and then try to show evidence for its effectiveness, and hopefully later on you can also show its efficiency. And initially, what I mentioned already is that it was quite successful, thinking about how we have tackled and sometimes even eradicated certain infectious diseases, and have increased life expectancy also in a lot of other more chronic diseases. But we are a bit stuck. So we don't see at this moment much improvements anymore. So why is it now not doing so well? Actually, and one of the things is that actually quite a lot of the problems that we are facing now, the relatively easy problems have been solved, and that's where we move more to the persistent problems. There is something wrong with the persistency of the problem, the structure of a problem, and the way we try to solve it. One of the problems is increased aging. So we have, only because of that, an increased care demand. Because actually, if you don't change anything else, like problems with lifestyle, we have more chronic patients. So how can we do that? The idea is, in many cases, one of the intervention thinking is around self-management. So at least in the Netherlands, one of the things was we need to have all sorts of projects. So one of the projects we did was looking at how has self-management been organized? How do people try to solve the issue that people need to stay at home longer themselves, and that they can be longer independent? So around that idea, we see a lot of developments of sensor systems, wearables, care robots, online tools, because they know we cannot have more staff, so we need to reduce the staff. So together with self-management, the idea is we need less staff for that. Now, how successful is this? What have you seen so far? Our conclusion was, because we did an evaluation study in the Netherlands, one of the outcomes was that the adoption was very low, at least in the Netherlands. We didn't see much of these sensor systems, wearables, robots, etc., finding their way into long-term, in care, elderly care. So we investigated why that was. Why is it that we see so little implementation? And when we did our interviews, we found out, first of all, that nurses were not enthusiastic at all. So from the care organizations, there was a strong resistance to apply these methods, because, first of all, it included for them a shift in their tasks, in the sense that they would have more administration and less personal contact. Many of the nurses go into nursing because they from the perspective that they can help people, and the direct contact with elderly people is what makes their job for a large extent satisfactory. On the other hand, patients, or the elderly, were also very hesitant and didn't want to go for it, because, first of all, they value that personal contact so much. Elderly people are often very lonely. And the other thing is that often it requires quite a bit of digital literacy to be able to work with it. And the elderly people are, up until now, that will of course change with new generations growing up, but the digital illiteracy is still quite high among elderly people. So what we found is that these innovations were not targeted towards where people felt their problems lied. It is much more complex than just thinking we need to use technology to make care possible. Another thing is that we have a lot of problems with overweight and obesity. And we're also doing quite a bit of research on that. And of course, very important interventions are more physical activity and healthy diets. Healthy diet simply means you should consume less calories, but better quality and more activity. Now, we also know that health education and communication have so far not been very effective in the field of prevention. You see that it benefits higher educated people, but people with low socioeconomic position hardly adopt the advice. And so they said, well, let's also try to make new interventions for that. And also in this case, we have seen a multitude of projects going for wearables, e-health, health apps, and again, with very disappointingly low results. And it actually didn't change from the effectiveness of most other health education and communication efforts. So what is the problem in many cases here? And we would like to argue that it is because of many different things. First of all, we notice that innovations are often poorly designed, first of all, in the sense that we don't see much attention for the user, not at all enough inclusion of users. So most of the research doesn't take place in a participatory sense. And if you look at the diffusion model of Rogers, who did quite a lot of work on why are certain innovations successful, is all about users. It's all about how do people perceive a relative advantage? What problem is actually being solved? Can people try it out? Can people see that when they use it, that there is a benefit? So can you try it out and can you observe it? But also, is it easily to manage? So in many cases, if you would do this already, you would come a long way. However, there's more that's going on. And that's the last one. What we often see is that actually new innovations are not automatically compatible with cultural values, patterns of behavior, routines, etc. So we see that they are trying to change practices, but don't pay enough attention to things like culture and structure in itself and routines that need to change. So there is, in many cases, not a good fit. There's not only not a good fit with the users themselves, but also with much more broader contexts. And especially this one is an issue. So sometimes these types of innovations find their way smoothly, particularly is it relatively simple, but often not. Basically because there's insufficient attention to the users and insufficient attention to context. And because of that, actually, stakeholders resist it. So, to sum up, the two main strategies for changing things more radically is, on the one hand, these top-down reforms that try to change the structure, but implicitly assume that practice and culture will follow. And on the other hand, we have all these bottom-up system change innovations at pilot scale that don't scale up to change the system. They focus on changing practices, but they run into all sorts of cultural and structural barriers. So at one point, that was part of the reason to write the book, is, well, what would be a way forward? What could we do if you, obviously, system change is highly complex. So maybe we should consider it to be complex and not try to simplify. And that's what's often done. We shouldn't simplify. We shouldn't go for reductionism. We should embrace that complexity. It's complex, period. So let's look at it in its full complexity. And that means that that was actually the start of a whole new theoretical, conceptual framing, which is called system innovation and transition theory. It has its roots in the 1990s, this thinking, mostly based on historical analysis of large change processes. That was the roots of this field. But apart from this descriptive part that they want to see in the past how things are going, the idea here is, can we also use these insights into a forward-looking thing? Can we make it more so not only for just retrospective analysis, but actually use it for action in the future? It was originally developed in the mobility and energy sector, so not in the health sector. The translation in the health sector only came around 2005, 2010. That's when these ideas that were developed in these other fields were also piloted and implemented in the health field. The focus is very much on sustainable development from this body of literature. And for the health system, that's not a bad thing, because basically what I told you already, that about the values that are so instrumental, so grounding at the health system, is that basically sustainable development is about balancing values. In most of the sustainability, they talk about people, planet, profit. But of course, you can also look at those links like accessibility, affordability, appropriateness, quality, equity, etc. So it is about balancing values. So we can also use that for the health system. And what are key concepts? First of all, the system thinking itself. Second is the issue of persistent problems, about the idea about how systems come about and how systems change. An important concept is the multi-level perspective and transition phases, as well as, and I'm taking out one of them because otherwise it will be a bit too complex, but one of the prospective, formative frameworks is transition management. So I will briefly go into that and then show you how we translate that in real life projects. So quickly, System thinking is the school of thought that focuses on the interactions of elements of a system and looking at them as a whole. So not cutting it up in bits and pieces, but looking at it in an integrated way. So radically moving away from reductionism. Also assuming that there are lots of feedback and feed-forward loops in the system, not a simple linear cause and effect relationship. There is no such thing as such an easy cause and effect relationship. It's all feeding into one another. And there are trade-offs. So if you understand how a system works currently, and you can get an idea about the systemic behavior. And that means if you understand that behavior of the system better by looking, for example, at past processes, but also failed innovation, not only successful innovation, but also failed ones, or successful reforms, also many of the failed reforms, you can anticipate better about what works and what doesn't work in change processes at that level. And that can help you when you try to design and implement interventions. So that is a very important basic thinking of system innovation and transition theory. Then the idea of the persistent problem is that, first of all, why are things, all the relatively easy problems have been, many of them have been tackled. What we are now stuck with is those problems that are really complex. So they have many aspects, many actors. That makes them difficult to solve. And you can see that easily by looking at all the failed innovations. And they are what we call embedded in the system. And that means that they are systemic in nature and systemically reproduced. And I will go into that a bit more, what is meant with that. Actually, that means that, sorry, just to say here, that means that if you want to address persistent problems, you run into systemic barriers. So that's another important concept, systemic barriers. And what are now systemic barriers for many of the changes that we foresee for a better healthcare system? Is first of all, that it's important to realize that many of these barriers are actually success factors of our current system. That's why it's so difficult to let go of those. They are strongholds of past success. Like what we now see nowadays is the problem of standardization is, of course, has been extremely successful. It's not there for nothing. The standards have improved medical practice. So if we need to acknowledge now that not all patients are the same, and that de-standardization has led to such an extent that we do too much bureaucracy, and so that we need to get more flexibility in the system, yeah, it's not so easy to let go of standardization, because how are you going to do that? We don't know. We don't know the effect, and we are afraid that if we let go of standards, that actually the quality of care might go down in such a way that actually we lose that. So it leads to a lot of uncertainty. Another one that we often see as a problem in our system of looking at health problems in a more holistic way is the fact that everything is so incredibly specialized. But it's also, it started off around the early 1900s, is the start of specialization. Before that, we mainly had general healthcare. We didn't have the specialization. So nowadays, we have more medical specialists than general practitioners. So it grew completely out of control, also because of the fact that we give higher higher status to a medical specialist than a GP. So we see there that this is leading to such fragmentation that patients' needs are not matched. So, and quite a lot of diseases, new things, actually fall between the cracks of fragmentation. But giving it up is quite difficult. It has to do a lot with own positions, changing habits, etc. And what will we lose? Will we then have all generalists, and can we then look at it in depth enough? So there are lots of problems in setting up multidisciplinary teams, for example. Proto-professionalization is another one. So this whole idea of medicine fixing ill people by very specific treatments with pills or other therapies or so. And is that people start to think very much as in that sense. So while the earlier things, the improvements in hygiene and food quality, etc., were more general treatments, that was, of course, in the 19th centuries, the most advances were reached in that sense. We now have very much the cure and care modus. And that cure and care modus is so internalized that people actually do very much prefer themselves a pill over a change in lifestyle. And then evidence-based medicine, that has been a very important and increasingly popular way to address effectiveness in the system, also means that quite a lot of well, initially the RCTs were much broader and were supposed to include professional and patient knowledge as well. It has become an equation of a meta-analysis of RCTs, evidence-based medicine, which is and RCTs are quite reductionistic in their setups and in many cases not very inclusive. So it is another problem that many of the things that more holistic treatments often are not easily to solve and show effectiveness through RCTs. So quite a few very promising new innovations actually fall between the cracks of the reductionism of RCTs that are now also used to structure guidelines, protocols, and standards. So there is a downside to it as well, as we see nowadays. Now, since we see the success of, then how do systems change? That's the next question. How do systems develop? Because systems do change. We can say it's difficult to change them, but they do change. And the structuration theory of Giddens is one of the most well-known and quite famous social theories about how systems come about. How does structuration, and what they mean with structuration is both the cultural as well as the more infrastructural, the structure, the hard side. Culture is seen the soft side of structuring elements, and infrastructure and rules and regulations are more the soft side of structuring elements, is that they are based by actors. When actors try to change things, they become agents. So agents are the ones that build structure. They make it. It's man-made. It's nothing else than that. It's not there by itself. It's only there because it's man-made. But once they are installed, we see that structure has a structuring consequence on the behavior of agents. So they become prescriptive to the behavior of agents. So there comes a loop. So agents make the structure, but then the structure is going to prescribe more or less what the agents do. And when we say systems get increasingly higher levels of structuration, and that means that it becomes so solidified that actually the agents lose their agency. They don't even question anymore why things are the way they are. They simply do it. They are being more or less brainwashed. And this is how we do it. Yeah, our body is a mechanical clockwork thing, and we replace certain elements. Our health system is basically an illness system because we focus mainly on cure and care. We forget about prevention. So it starts ingraining in all things what we do and how we organize it without questioning anymore. So even if you are unsatisfied, you're often not able to think out of the box. And this is another way of showing this in relation to the health system. If we look at Giddens' structuration theory, you have on the one hand the culture and the structure, which are the structuring elements. So the culture is the values on life, medical ethics, expectations about patients, treatment paradigms, etc. And on the structure side, we have the laws, the medical protocols, the healthcare providers with their education, the profit structure, power structures, the whole infrastructure, etc., which lead to certain practices, and then you have the actors, which the patients, families, citizens, doctors, nurses, etc., who can then change things. So together, this culture, structure, and practice forms what we often call a regime. This is the dominant way we do things. We have landscape trends like aging, technological developments, economic developments, levels of empowerment of certain groups that put pressure on the regime that things need to change, like we see nowadays. On the other hand, we have all these experiments going on because people regularly try out new things, either with subsidies or because they want to do it themselves, to try to change practices. So these developments, these landscape trends, both and the niche level, put pressure on the regime to change. Oops. Now, transition management tried to come up with a structure on how you could use these insights to help and they focus more on these bottom-up issues that you say, well, you need to make a network of people who feel that things need to change in a holistic way. Then you should try to come up with a shared vision on how you could make desirable futures and what sort of structure, culture, and practice could go with this. And then you should try things out. You should have a transition experiment. You should have pilot projects involving many disciplines, many actors, conducting transdisciplinary research, so more or less in participation, action research. And then you should have these reflexive learning processes. Now, the thing is, I hope, do I still have 5 minutes, Rosina? Because I'm at the time of 40 minutes. Would you mind if I do 5 more minutes?
If everybody agrees, I'm fine. Yes, it's being interesting. Yes, there are some questions as well, but we can leave them for afterwards. Yeah.
The thing now is then how the heck do you start? Because the idea, I think transition management is like, yeah, you have to start somewhere. You cannot just take on the whole health system and say, okay, what are we going to do? So you do, So you do need to pinpoint an action somewhere and then move from there. And so it's not grasping the complexity at once. It is starting from a certain problem, a defined problem, and then taking a broader perspective. So, and I want to do this, like for example, I want to go to that later on. Let's, school lunches. We have what I said before, the problem of obesity, overweight and obesity that we see nowadays. And it already starts early in life. And we know that it is important, when people are already overweight or obese in their young age, it's very likely that they will be so in later life. So trying to prevent overweight and obesity as early as possible is important. We know that. So instead of just on looking at providing education, which I showed already is not a very good, it's important, but on its own, it doesn't do it. Health education, health literacy is relevant, but not. Oh, sorry about that. My telephone is on. So sorry about that. So you can think of it in a broader way and take a more holistic approach to the problem of healthy diets. And that would mean that you're going to look at more at the food environment and at the food system as a whole. We also know physical activity is important, but the most important thing is diets. Because you cannot train sufficiently. If you eat too much, it's hardly impossible to train sufficiently to get your weight down. So food is the first and foremost thing to focus on. And so you might have an idea about changing things in schools, because schools are places of education. But at the same time, in many cases, there is provision of food there as well. So what you see is that people start thinking about, well, how can we make those lunches more healthy? However, it would not be a good idea if you take the system thinking, you would not consider just saying, okay, we want healthy lunches. You take the idea, but wait a minute, there's something wrong. If we have so many overweight people, there's also something wrong with our entire food system. Why is it that this supply and everything actually makes people eat so unhealthy? How can we take care? And isn't it all, and if we're talking about food, we're talking about another system. We're talking actually about, basically, we're talking about three systems. We're talking about the educational system. We're talking about the health system, prevention in this case, and we are talking about the food system. So actually, when we look at this problem of unhealthy diets of young kids, we actually have three sectors that we need to consider. And it needs to fit into three sectors. And at the same time, we want to change three systems. So from that perspective, you can see that, wait a minute, if you would only think about healthy lunches, that would be so many missed opportunities, and it would not really bring that much difference. Let's take a much more holistic approach and then try to see what we could do. Why not also think about ecologically produced food? Why not let children prepare their own food and increase their food preparation competencies? Maybe you can actually have children grow that food so that they learn how to grow food, or work together with farmers so that they know where the food comes from, so that it becomes extremely lively. And maybe also have them to do some volunteer work at farms, so that we have much more stronger linkages between the rural and the urban. Why not also have parents completely involved with the children, have starting discussions about this? Maybe for equity situations, you need to do some sort of pooling of resources or differential pricing. So in other words, it might also be that you need to change policies, because it might be that if you try this out in one school, you might want the municipality to become involved to try to see whether they can scale it up. Maybe also linked to the different sectoral organizations that are in the area, etc. So it becomes a bit of a network, and also, of course, involve teachers of how can they manage this. So it becomes a much broader networking activity, where you not only look at this, but try to understand how it could work in one location, try to broaden and link this. But for that, often the scaling issue, you need to link up with policymakers so that these networks become much broader. And make this into a reflexive learning thing, not just go for an RCT and see the effectiveness, but actually do this much more broad. Now, this is what I would like to leave you with. I'll stop share so I can actually see the chat.
Oh, amazing. Thank you very much,
A bit of an
Jacqueline.
idea. So in these types of launching projects, we work together with people from health professionals, from the educational sector, from the farmers communities, from the municipality, etc. So you work much more, in collaborative settings.
Thanks a lot for sharing, Jacqueline. We have a couple of questions in the chat. Maybe, Michael, do you want to comment, ask them directly?
Yeah, thanks very much. Thanks, Jacqueline. Very interesting. All of this was slightly familiar to me because I looked into what Health Holland was doing with its missions from about 2021, 22. And we could see there that the intended transition was from a sick care system towards well-being. Would you like to comment on the success of the first iteration of the program, which established PPPs and then Koolsadamen? When we looked at it, effectively, what we saw was spaghetti. So a lot of strands of spaghetti that lots of bits of sauce clung to, lots of activity at the bottom, not much accountability at the top, and not much linkage between the middle. So that's my first question. And in relation to that, I'll be very, very keen to understand how you think that National Strategic Health Initiative should move forward. And then the third piece on the school meals, looking at that as a system and considering it from a systems dynamics perspective, what kind of modeling did you consider to evaluate the effects of various interventions in that systemic response, and to measure the outcomes in terms of parameters? I'll leave you my number. I'd love to have a straight call with you.
Yeah, these are super important and relevant questions. They're both not easy to answer, basically because by looking at things, by embracing complexity and looking at it more in systemic ways and much more participatory and looking for integration doesn't mean that is easy. And we see especially integration is extremely complex. Integration between different groups and initiatives at the same level, and the integration between different levels.
So I think that I just wanted to intervene in that at that point. So talking with I can't remember his name, Nick, who runs Health Holland, and the issue is really around wasted effort and duplication. And let's say you're effectively trying to introduce, let's say, structure and discipline within chaos at that testing level. So what are your observations on that?
Oh, that's the case. And that's what you run into. That's what happens when you do this. And what you mentioned, that the chaos, duplication, that's what I mean with integration, is that people integrate their efforts, that they work together, that they formulate the ideas, that they have more of a joint vision. And what we see is that, because there's also complication about developing visions about where you want to go to, is that people, when they are in change mode, they have the people that do that have a strong motivation. But it doesn't mean that my motivation, what motivates me, is the same as what motivates you.
No, I understand that. What I'm saying is that there seem to be a lot of duplication and like efforts engaging in the same problematics in slightly different contexts, which were not joined up in any way. So the question from let's say an investment effectiveness or an innovation effectiveness perspective is that are we getting the best out of our resources and energy engaged in this activity? So you saw in many different health districts and regimes and systems, very different duplicate behavior, duplicate projects.
Duplication is not the problem as such. It is a problem if you don't exchange and don't learn from one another. So what we say from the transition perspective is that you do need many flowers to bloom to try things out in different contexts. Some of it is duplication, because you want to know also on purpose whether things in place X also works in place Y. So there's the only thing that is often not intentionally coordinated and intentionally learned from. And
okay, that's great.
You need to join up efforts.
Yeah, and I think that seems to have been the observation from this first cycle, that coordination or that interchange or that reflection or that commonality in terms of the objective and the approach was probably missing.
Is missing, and the program will learn from it. They will see, oh, well, we did this. This is a positive thing, but we're still missing. So if they have themselves a reflexive learning approach, they will learn along the way, because we don't have a blueprint on how to do a system change. We don't, because systems are too unpredictable. We don't know if we do X, that Y will happen. We don't know.
But I heard that the program was to be stopped at the national level, so I don't have any indication of how it will continue.
Well, it's also we also had a prevention program, health prevention program in the Netherlands, and that's also stopped. So they tried to make this move from from care and cure towards prevention, and that was totally kicked out of the window because of different political views in which they want to go back to a more individual approach. So going back to health literacy and communication.
Very interesting. Listen, sorry, I don't want to take everybody else's time, Jacqueline. I'd really love to have a call with you. I've just popped my email in there if you want to get in touch.
Okay, great.
Thank you.
Thank you. Are there any other questions or comments, Rosalia? Yes.
Yes, hi. Thank you, Jacqueline. That was extremely interesting. And I was just saddened to hear now about a health prevention project that was actually thrown out, because I really see a lot of value for this kind of work. I've been involved with systems thinking, social change, social impact for a number of years, and I now live in the Netherlands. But I'm originally from South Africa, and I actually set up an elder care project in South Africa, and it was for displaced elderly people. So they had to leave their home, which was Rhodesia or Zimbabwe, and to move to South Africa because of political and economic reasons. And I worked on that project for a number of years, and it was extremely interesting to do the research and to understand the community needs, etc. And we actually without having to go into too many details, but something that we also noticed was that people didn't have that social connection. So unfortunately, I came into the meeting late because I couldn't get in, and I was then thrown out because Wi-Fi went. So I've missed quite a bit. So, but I think that. I think the what we did was some things that we did was actually besides I'm a psychologist, so we did a lot of psychosocial support, understanding community needs, but also we actually realized that people weren't socializing, weren't connecting. So I understand what you're saying about the AI, that they wanted that it was it's an entrenched system. They want the people contact. That's all the elderly people know. We want people around us, and to actually find that balance. So what we did was we actually created social connection activities, and we did something that was I started a project called for Essential Foot Care Days, because what I realized was that elderly people can't reach their feet, so they actually can't cut their toenails. And and because of that, because of the health issues with diabetes, etc. There were ulcers on the feet. There were other problems with the feet. So I created these essential foot care days where we took care of the elderly people's feet. And within that day, that social activity, we had a lot of people around, people doing basic treatments, and we found that these elderly people were connecting so nicely with each other, developing a relationship with the therapist. We were really it was part of another project that I set up to create work opportunities for marginalized young women in South Africa. So I taught them how to do a very basic foot care. And we started to heal, past wounds and to align people and to connect society, etc. And it was so incredibly valuable. It was so incredibly valuable. So I just think that the work you're doing is really incredible. And there really is, there's not one idea that will solve all the problems, but rather that we can actually start igniting little, or like you said earlier, planting little seeds, and then see them sprouting up here and there, and then also to eventually create a stronger system.
Yeah.
For all.
Yeah, but it's not a but, it's an and. And looking at that in a structural way from a systemic perspective will help it grow. It won't usually grow automatically.
No, it won't. You have to facilitate the change. You have to literally go, you've got to have that presence. Go in there, start working, establish the trust. Establish the trust, getting people to buy into something. And yes, I think it's amazing. Do you mind if I contact you on LinkedIn?
Sure.
Thank you very much.
Absolutely.
Thank you.
Fine. Yeah.
Well, thank you very much to Jacqueline Broerse for this very interesting presentation. We can see in the comments that all the participants were extremely happy with your presentation. Thank you, Jacqueline. And thanks also to the participants who have provided some questions. The presentation will be recorded online. It will be online on YouTube, so you can find it in our channel for future catching up with all that has been said. And as has been suggested here, there were people asking for a part 2 discussion in the future.
So practical challenges that are still there. That would be a good one.
There are a lot of challenges still to tackle, and a lot of questions to answer on how to make sure that we also break these or address these barriers for creating these arenas, these transition arenas. So thanks a lot, and we are happy to continue exploring together how to achieve these arenas everywhere and for all the challenges that we are seeing in our communities. Thank you very much.
Thanks, everyone. Great session.
Sorry, I lost you for a minute, but that's okay. Okay, bye-bye.
Thank you, everyone. Bye-bye.
Bye.
Thank
Thank you.
you. Bye.